Good evening. I am Dr. Anil Parikh, Medical Director IPCA. It gives me a great pleasure to welcome all the medical fraternity across the country who have logged in for today's evening CME. Uh, Today we are really fortunate because this is the first Indo-British colloquium on hypertension, where we have a galaxy of both international and Indian experts who are renowned in their both as we have excellent speakers as well as panelists who are very renowned in their area and well known, and their contribution is recognized across the country. And uh, I am going to we have uh, Dr. PK Sahu as the chairperson for today's meeting. Dr. PK Sahu is well known across the country for his contribution in cardiology. He's currently senior consultant and a cardiologist and director interventional cardiology at Apollo Hospital, Bhubaneswar. He is in charge of DNB cardiology program at Apollo Hospitals, and he has done his graduation from Medical College Behrampur and post graduation from SCB Medical College Cuttack, and postdoctorate he worked in Lokmanya Tilak Municipal Medical College and Sion Hospital, Mumbai, and advanced international course training at various places, Ruin University, France, Miyazaki University, Japan, and also Harbin University, China. And formerly, he has worked as senior lecturer at Department of Cardiology, LTM Medical College and Sion Hospital. He has been head division of cardiac sciences and Kalinga Hospital in Bhubaneswar, and he has numerous publications in reputed journals to his credit, as well as he has written book chapters. Uh, so he will be introducing the subject as well as the speakers, and then we have our own very own Padma Shri Dr. Venkat S. Ram, whom I have known since my postgraduate days, and I can say that he is can be considered as the foremost expert on hypertension from India, who is well recognized internationally as well and has numerous contributions and entire lifetime devoted to hypertension research. He will be introducing the panelists, and then he will guide the panel discussion for today's important scientific program. It is going to be academic fest, and he's director academic and scientific affairs, Indian Society of Hypertension, professor of clinical medicine at University of Texas, and then director Texas Blood Pressure Institute, Dallas, Dean Maguire University, Australia, and rated as one of the topmost expert in hypertension in the world, and authored more than 410 publications, 9 book chapters, and books on hypertension, and recipient of Lifetime Moses Award from American Society of Hypertension, received Padma Shri from the Indian government, and also from Harshvardhan, recognized as the global hypertension icon. So it's a great pleasure to welcome all of you, both the faculty as and the panelists, as well as the audience who have logged in for this academic fest. And without any further, now I request our chairperson, Dr. Prasant Kumar Shahu, to kindly start the proceedings.
Thank you, Dr. Parikh. In fact, it is my honor to be chairing this session in the galaxy of so many international speakers and also researchers. As I understand, this is the first Indo-British Cardiovascular Colloquium, joint venture between the British and the Irish Hypertension Society and the Indian Society of Hypertension. We have 4 speakers for today's colloquium that we are going to discuss on. First is Professor Neil Poulter, who is the past president of the British Hypertension Society and the International Society of Hypertension. In fact, I had the opportunity to meet Dr. Neil Poulter in one of the meetings, and to introduce himself in such a short time is a very difficult task. But definitely, he has a lot of research work, and he has spent 5 years in Kenya coordinating a collaborative hypertension research program at the Wellcome Trust Research Labs in Nairobi. He was a co-principal investigator of the WHO oral contraceptive case control study at University of London Medical School. Currently, he is the co-director of the International Center of Circulatory Health and founding director of the Imperial Clinical Trials Unit, a past president of the British Hypertension Society from 2003 to 2005, and also a past president of the International Society of Hypertension from 2016 to 2018. He has more than 650 published articles in peer-reviewed journals and co-authoring textbooks and international and national guidelines, which we always refer to, and has a devoted senior management role in international trials like the ASCOT, Advance, Excel, Devote Leader, and the Creole trials. Presently, he is the chief investigator of the May Measurement Month, an annual global blood pressure screening campaign initiated by the International Society of Hypertension. It will be a pleasure to listen to Dr. Neil Poulter, who will be talking on the global burden of hypertension and how to lower it. Because there can be no other fit person to talk on this because of his extensive work. Welcome you to this colloquium, Dr. Neil Poulter. Then we have Professor G.S. Wander, who has been a real stalwart in the field of medicine and cardiology in our country. He has more than 298 published papers and 142 foreign reputed journals like the Lancet, Nature, JACC, European Heart Journal. And presently, he is the principal and professor of cardiology, Dayanand Medical College and Hospital, Ludhiana. He is a voracious and a prolific speaker and also a researcher. He has been the director of the Physician Research Foundation of the API, which is a branch of the Association of Physicians India, and for 2022 to 25, and also has been the past president of the API of 2016 to 17, president of the Hypertension Society of 2012 to 13, awarded the BC Roy National Award for year 2006, and the chief editor of Postgraduate Medicine textbook, which is a very important textbook which is followed in our country. It is always a pleasure to hear Professor Wander speaking on hypertension and allied subjects because the astute clinician, and he'll be discussing with us a sneak preview about the latest Indian guidelines for hypertension, which is really important in 2025. The next speaker will be Dr. Peter Siver, who is a past president again of the British Hypertension Society and the European Council of the British Hypertension Foundation, also the consultant physician to the United Kingdom. Now, he has been a professor of clinical pharmacology therapeutics in the National Heart Lung Institute, Imperial College London, and consultant physician also at the same place and the NHS Trust, past president of both the British and Irish Hypertension Society, the European Council of Blood Pressure, and Cardiovascular Research and National Institute of Health, UK. In 210, he was felicitated by the International Society for Hypertension for his contribution to clinical pharmacology and therapy for arterial hypertension. He has been bestowed in 2021 with the Imperial College Medical for meritorious service in the college and the past joint editor-in-chief of the Journal of Renal Angiotensin Aldosterone System. In fact, I was not aware that there is a journal of the RAS system, which is very interesting, and has been the author of 600 peer-reviewed publications. Professor Siver's research interests include pathophysiology of vascular disease, evaluation of antihypertensives, drug therapy, and the impact of multiple risk factor intervention of the prevent cardiovascular disease. Professor Siver will be talking on BP variability, the mechanisms, and the clinical significance. This is a very important topic, and we hardly give much of importance to this because it is also very important for us clinicians to know about the BP variability. The last speaker will be Dr. Jabir Abdul Katti, a good friend of mine. He has been a high-level interventional cardiologist, not only that, but has been a director in cardiovascular clinical research at the Lissi Hospital and has to his credit 68 publications, investigations on randomized controlled trials, 23, among which we are also collaborating with him, and the registry and 16 registries. He has been the National Vice President of the Indian College of Cardiology, the Secretary of the Cardiovascular Research Society, the Vice President of the Heart Failure and Transplantation, the Asia Pacific Steering Committee member of Artemis Clinical Trials, and the National Team Leader of the Luminara trial. Besides this, he has been holding many executive posts and has organized many conferences like the CSA National Heart Failure Conference, the Cardiac Imaging Conference, or the SCIP, the Interventional Cardiology Council of Kerala, the Internal Medical Medicine Conference in collaboration with the RCPS of London, the CSI Kerala chapter conference, the internal medicine conferences, National International Council midterm meet in 2014, and the summer conference of the Cardiovascular Society of India, the Kerala chapter. Welcome, Dr. Abdul Katti. In fact, he was speaking on hypertension control, the turning point for heart failure. So I welcome all these four speakers. Dr. Neil Poulter will be starting with his talk on global burden of hypertension, and each speaker has been allotted 15 minutes. And after we complete all these speakers, Dr. Venkatram will be taking over and will be having a panel discussion. He will be moderating panel discussion, and there will be audience participation, and all our experts will be answering the questions. Over to you, Dr. Neil Poulter.
Thank you very much indeed, Dr. Sahu. And I'd also like to thank IPCA for facilitating this collaboration between the Indian Society of Hypertension and the British and Irish Hypertension Society. I'm absolutely delighted to get a chance to speak. And my job as the openings talk really is to paint the background on which all our work in hypertension is involved, a sort of global look at the burden of this problem, hopefully with a few practical thoughts on how we might lower it. This slide shows what may be my conflicts of interest. I don't believe I have any, certainly in relationship to this talk, but nevertheless I show that for political correctness. So by way of background, let's look at the situation around the world. And this shows the number of adults with raised blood pressure between 1990 and 2019. Over those 30 years, you see the numbers affected almost doubled from 648 million to 1.3 billion. The color scheme here shows that the red ones at the bottom, they're undiagnosed. And as you can see, that's about half the people around the world. The dark green, the small dark green section at the top, they're the ones who have been detected and treated and are controlled to 140/90. So they are a small minority. 10 years ago, I wrote this in the Lancet that raised blood pressure is the biggest contributor to the global burden of disease and to global mortality, leading to 9.4 million deaths each year. But that problem's getting a lot worse. So as you see, as you go to 2019, the 9.4 million has now gone to 10.8 million. And that is far greater. That's about 30,000 deaths per day due to raised blood pressure. That's far greater than COVID ever caused. And of course, the COVID deaths are quietly, one way or another, disappearing, while this number of deaths are going up and up as the world gets older and as the population gets bigger. So the absolute number is getting much worse. And that continues. This problem's going up, and the most recent data, not shown here, is over 11 million deaths each year. So this is a continuing huge problem, and we've got to do better than we're doing. So if we turn to low and middle income countries where most of hypertension is, this is the hypertension care cascade. And it's the same pattern, whichever of the four low and middle income regions shown here. Now, if we just take any one of them, let's take this one, bottom left. The pattern's the same. The first column is 100% of hypertensives in that region. And then the next column here, what percentage ever had their blood pressure measured? And you can see that's only 2/3 when people were found to have hypertension. 2/3 had ever had their blood pressure previously measured. The middle column there you see is those diagnosed, that's less than 40%. Then moving to the right, the proportion treated, about 1 in 5, and those who are controlled, less than 10%. Now, it varies in the different lower middle income countries, but that's controlled to 140/90. And as you'll appreciate, currently we're suggesting that people should go to less than 130/80. So it's a minuscule proportion. However, if we just focus on the percentage controlled here, it occurred to me when we saw these sort of data 2017, 16, 17, the best you can do with this proportion controlled is determined by those who've been diagnosed. So all you could do is bring the red arrow up to the orange arrow, less than 4 out of 10. That's the best you could do. So this is a key gateway. The diagnosis, the screening of blood pressure opens up the potential to controlling the blood pressure. And that was the background to May Measurement Month being delivered. And thanks to everyone in the audience who's been involved with May Measurement Month in the past. But that was set up just to raise the awareness and get people screening blood pressure around the world. And just to give you an update on those LMIC data before, these are data from the first 3 years of May Measurement Month, including only about 3 million people who were screened. And you'll see here about a third got hypertension. 60% of the hypertensives were aware. Just over half were being treated. That's pretty good. But those controlled to 140/90 was a third. 1/3 of patients with hypertension around the world, of 3 million around the world, were controlled to 140/90, and we're now saying 130/80. That comes down to less than 1 in 5 if you take 138 as control. Of those who are actually treated, just over half are getting control again to 140/90. So that's the state of play, at least based on the first 3 years of May Measurement Month. Now, let's just turn to the question of lowering the blood pressure of the population, not just the hypertensives, of the population around the world. And if you wanted to do that, you've got to cover prevention, diagnosis, and management. And the first thing you need to do, I think, is pivotal, is you've got to raise awareness of the population. You've got to educate the population about blood pressure, get some understanding. Once you've done that, you can then build on the next phases. And the second thing is to reduce that population blood pressure. We'll come back to that. Then we go on to increase screening for blood pressure, which is clearly important to pick up those people who've got it. And finally, to improve the hypertension management. But what I want to do now really is to focus about reducing the population's blood pressure. What are we going to do that? Well, first of all, what's the rationale for doing it? And this is really important, because only about half the adverse cardiovascular events that are caused by raised blood pressure, about half of them occur in the normotensive range. So if you only could do everything with hypertensives perfectly, you're still missing half the action. The mean blood pressure of the population predicts the extreme. So if we lower the mean blood pressure, the proportion with hypertension will come down. And small changes in the mean population blood pressure generate large benefits in terms of major cardiovascular events prevented. So what should we do at the population level? Well, in collaboration with gyms and supermarkets and with the weight loss industry and food outlets, here are a few ideas. At 12 o'clock, lose weight. We all know that. But that needs to be, we've got to get in with the weight loss industry and with the food producing outlets to help to reduce body weight. Obesity is a huge problem. Then moving round to 2 o'clock, increasing exercise. And that needs to be generated again through linking up with gyms, but community-based exercise programs. Then moving round to that beetroot, that is just to highlight the need for nitrate-containing foods. We need more of those, and I'll come back to it, more of those to lower the blood pressure population. All part of things at 6 o'clock there, more fresh fruit and vegetables. Moving round to about 8 o'clock, potassium-enriched salt. Very difficult to stop people using salt. It's much easier to get them to swap the salt that they use by using potassium-enriched salt. And then just about 10 o'clock there, that advertising, restricting the advertisement of unhealthy foods and promoting the advertisement of things that are good for us. So that's the generic idea of what we need to do. And here's some of the supportive evidence. This is a recent trial in China of people with raised blood pressure over the age of 60, or those who've had a stroke. And this was the effect of just swapping their normal domestic salt, sodium chloride, for potassium-enriched salt. This is 20% potassium chloride. And what you see here, these huge differences in stroke, cardiovascular death, and MACE, just by swapping the salt. This is a real message to us all that this is what needs to happen at the population. The other thing is nitrate containing foods, and most people don't know much about it, but this goes back 10 years when beetroot juice, which is high in nitrate, was given to patients versus the same juice but without the nitrate. And this 250 mils of beetroot juice was given every day to the population. And here you see the benefits, placebo-controlled benefits, about 8 millimeters systolic, including in ABPM. That's a huge effect. And so I think this is the sort of thing that drives the promotion. We should be trying to promote these sorts of changes at the population level. If we now look back at some of the key things we mentioned earlier, body weight. These are the data from 1 year of May measurement month. It's the strongest predictor of raised blood pressure in the world every year in May measurement month. This is based on over 1.2 million screenees in the first years we did it. Red systolic, blue diastolic, and you see here the difference in blood pressure as you go from underweight to obese. 8 millimeters systolic blood pressure. Massive benefit. We've got to do something about the problems of overweight, and I don't mean injecting people with GLP-1 agonists. This is where it all begins. There are now more young people with overweight through calorie excess than there are young people who are starving around the world. And that's a huge target. We've got to turn that round. One of the main areas to hit, of course, is fizzy drinks. If you look at the Lancet Commission on Hypertension to lower blood pressure, this, I think, is a striking statement. It's striking that all blood pressure guidelines, and this is true, they all agree that individual lifestyle modification is the cornerstone of prevention, and it is the first line of treatment. As physicians, we're not very good at this. Most of us weren't taught what things you should do in our diet. But this is the recognized recommendation. We should clue up on it, and we should pass on that information to our patients, making it easier for them to lower their own blood pressure. What should they use? Well, the things we've mentioned, I've highlighted them. This is the list from the Lancet Commission on Hypertension, but reduction in salt, increasing potassium. So potassium-enriched salt, increased dietary nitrate. It's there in beetroot juice, raw beetroot. Once you boil the beetroot, it's no good, but green leafy vegetables in salads, increased physical activity and in fitness, and weight loss. These are low-hanging fruit. We should focus on this. Now, given that lifestyle may not be sufficient for many of our patients, what drugs should we use? Well, nearly all the guidelines have come together to agree with this over the last few years, and that's unusual globally, but they nearly all have come up with the same statements, and that we should be starting with 2 drug classes when we're treating our patients with raised blood pressure. And ideally, these 2 drug classes should be combined as a single pill. Well, what 2 drug classes? Well, we haven't time to go into that now. It's a short lecture. But this table from the ISH guidelines of 2020, I think, is really good. I think if you work on this basis, I think you'll optimize the therapy of your patients. First of all, the treatment should be evidence-based in relation to morbidity and mortality prevention. Not how much creatinine or albuminuria, but on the effect of morbidity and mortality. Secondly, we should be using once-daily regimens which produce 24-hour blood pressure control. Thirdly, the treatment obviously has got to be affordable or cost-effective relative to other agents, and I appreciate that varies greatly around the world. Point 4, they've got to be well tolerated. If they're not well tolerated, people won't take them, so there's got to be reasonably well tolerated. And 4 or 5 main drug classes are well tolerated. And fifthly, the evidence of benefits of the use of the medication in populations to which it is to be applied. If you have a stroke, what is the evidence of post-stroke treatment? If you've got diabetes, what is the evidence, etc. If you use these 5 points to guide which drugs you use and how to give them, I think that would be a very good, I think all our patients will do very well. So finally, addressing this global burden of high blood pressure, in summary, the first thing is it is the top priority in global health. Nothing else kills people as well as raised blood pressure. So in terms of prevention, I think we need to educate the public. We can get through social media. We have to get to the public so they understand it. And it's about promoting health around that education. Things like potassium-enriched salt, beetroot juice, or high nitrate containing products, relatively easy to push. They're cheap and they should be done. Next, we need to increase the diagnosis. We need to enhance screening. We cannot treat, and therefore we cannot control raised blood pressure if it hasn't been diagnosed. That is fundamental to the project. And so finally, we need management, and we need evidence by ethnicity. We've had far too many, there are virtually no trials at all in the South Asian population of optimal therapy. The Topspin trial was announced at AHA, showing differences amongst the, or rather showing equivalence amongst the combinations that are currently recommended, but that's important around the world. And so we need cheap, proven single pill combinations, and then once we've got them, they've got to be distributed equitably and delivered. And that delivery doesn't have to be with high-ranking cardiologists. Most of this, I think, can be done through task sharing. For example, in some parts of the world, the community health workers supported by eHealth can deliver an excellent service to the world. Thank you for your attention.
Thank you, Professor Polter, for your insight into the global burden and how to lower it. It was very interesting to listen about certain new concepts that you have put in, regarding salt sensitivity and all this aspect, and about this thing May month, this thing that is men's hypertension evaluation. Can I invite Professor Wander to speak on the latest Indian guidelines for hypertension 2025, a sneak preview? Over to you, Professor Wander.
A very good evening to all of you, and it's a great pleasure and a privilege for me to be talking here today in a session in which we have experts from across the globe, and my mentor, Dr. Venkatram, who is chairing this along with Dr. Sahu. The task in the next 10-15 minutes for me is to discuss what do we expect in the new Indian guidelines which will be coming in this year. Well, you all know we have the Indian guidelines on hypertension for the last more than 25 years, and these are all encompassing guidelines with such simplistic classification of hypertension in stage 1, 2, 3. We have given due importance to the isolated systolic hypertension. And ever since actually the Indian guidelines were released, we had the NICE guidelines in 2019. The Canadian guidelines came out in 2020. Dr. Polter mentioned about the International Society of Hypertension guidelines of 2020. The WHO came out with pharmacological treatment for adults guidelines. And of course, we now have a split of the European Society of Hypertension 23 guidelines and the European Society of Cardiology guidelines in 24. So there is a whole lot of data which has come ever since actually we came out with our guidelines. And there is a lot of literature which will be useful for us to have a look at. And huge number of trials have come, which I will be mentioning a little bit. Just to talk a bit about the Indian scenario, Dr. Polter has beautifully covered actually the world global burden of hypertension. And we also have the fifth National Family Health Survey study, which was conducted in 2020. And as he showed for the world, the prevalence of hypertension in our country is 28%, 1 in 3 individuals. 63% of them are undiagnosed, 82% have never been put on treatment, and only about 10% of these people are on treatment. It's not only the ruralites actually where the control rates are less, even the urban population of India, the control rates are dismally low. So, whatever we discuss, as Dr. Poulter has started this May measurement month in which Indians actually participate very, very enthusiastically. We know as our population is aging beyond 70 years, almost the prevalence of hypertension becomes 60%. So we need to be more vigilant, not only with accurate measurement of blood pressure, because the WHO has taken it upon itself that the mercury sphygmomanometers have to be discarded. And now we have to use the electronic apparatuses for office, home, and ambulatory recording. The manual apparatuses can be used if automated devices are not available. And of course, the cuffless blood pressure devices have not yet been evidenced to be accurate, and so these are not to be encouraged to be used. We know, as compared to the Canadian guidelines, Indian guidelines, and also most of the Western guidelines depend on office blood pressure recording, since most of the data from clinical trials is available from the office blood pressure recordings only. And this August audience of about 1,000 delegates who have actually hooked in to listen to all these experts. It's indeed an honor for me to speak to such a large audience. We all know that more than 2 visits we should be diagnosing hypertension, and this is a large trial which we published in Journal of Clinical Hypertension, which shows that almost 6% individuals you will miss if you record blood pressure in one arm only. And of course, you will also miss atherosclerotic disease. So both arm blood pressure recording in this large trial with 135,000 patients. And so we need to emphasize to our physicians that both arm blood pressure recording, at least on the first visit, is very important. Home blood pressure monitoring is being emphasized world over. This makes people participate in their management. They become compliance improves, and also we know we are able to diagnose white coat and masked hypertension. And so home blood pressure monitoring is being encouraged world over. The method of recording has to be appropriate. We have to monitor it for 7 days. Otherwise, patients I have seen in my clinical practice, they start reacting and responding to one particular reading and they create panic. We have to tell them that it's the average of 7 days morning, evening reading with the first day reading. So proper explanation to the patients will always help. And we showed actually in this large India heart study involving about 18,000 patients that white coat hypertension is pretty prevalent in our society, almost 15%, and masked hypertension, which is even more dangerous, where these people are left without treatment, is to the tune of 20% of these individuals. So we have white coat hypertension, masked hypertension, early morning rise of hypertension, and even Asian population has been shown to have greater prevalence of nighttime hypertension. We have done some work in this country amongst physicians as to what percentage of patients, almost one third of patients own blood pressure devices, and less than that actually record their blood pressures. And as part of the Asian home blood pressure survey, which we did a couple of years back, we found that we don't we are not placed as well as some of these countries like Japan, Taiwan, or Singapore. And we need to work on this area and emphasize to our physicians that patient participation is important and we have to involve them in their treatment process, because compliance is a big issue in management of hypertension. Well, ambulatory blood pressure monitoring is not for all, but certainly it identifies white coat, masked hypertension, and as I said, nocturnal blood pressure. The apparatuses are a little bit intricate, cost is involved, and every 20 minutes recording has to be done during day and night. But certainly in selective patients, it's very important, as this Spanish study published actually 2 years back showed that if the clinic systolic blood pressure has an informativeness of 100%, as compared to that, the nighttime systolic blood pressure has an informativeness of 600%. So we can and we should use this discreetly in individuals where we feel there is resistant hypertension, for follow-up of our patients and where we suspect actually nighttime hypertension in our patients. Classification of hypertension is more or less standardized, although the Americans have now defined hypertension beyond 130/80. We heard Dr. Poulter that we all want to reduce blood pressures to lower than that. But what is more important is this lower part of the slide. The European Society of Hypertension has now emphasized uncomplicated hypertension, presence of hypertension mediated organ damage, and established cardiovascular disease, because your aggressiveness in terms of control that you want to achieve will obviously increase in individuals who have high risk, who have already got actually organ damage due to hypertension. The ESC guidelines are a little bit more simplistic. They have put it as non-elevated, elevated, and hypertension. I personally believe these are oversimplifications actually. This is the risk stratification, what I was talking a couple of minutes back to you, and you can see that a blood pressure of 130 to 139 with a diastolic of 85 to 90 can be very high risk in people who have established cardiovascular disease. So it's not just the level, also the risk factors, the organ damage and established disease. These factors will determine actually how much aggressively you need to control blood pressure. Of course, we need to control blood pressure in every individual who has hypertension. Although we do not have an Indian scoring system like the ASCVD for the Americans and the score system for the Europeans, but along with Dr. Venkatram and Rajiv Gupta, we did emphasize in the Journal of Human Hypertension that increasing age, male sex, high lipids, smoking, diabetes, these are simplistic ways by which a physician can judge whether the individual is actually likely to have coronary disease and cerebrovascular accidents along when someone has hypertension. Established and newer risk factors are being emphasized. Heart rate is, people are laying more and more attention to it. Lipoprotein little a is a risk factor, which we have shown actually that it is peculiar to Indians. After the blacks, Indians have one of the highest LPA levels. And of course, low birth weight, frailty, these are important issues, along with actually additional clinical conditions like gout, NASH, OSA. All these need to be emphasized in the newer guidelines. Coming to the management, this is of course a very familiar table that we combine the ARBs or ACE inhibitor along with calcium channel blocker or diuretic. As Dr. Poulter emphasized, the role of monotherapy is very little today. Only in very low risk individuals with stage 1 hypertension or very frail individuals you can use monotherapy. Actually, we have always emphasized that combination therapy is the way to go for hypertension, and it is even being emphasized more. Beta blockers are actually an issue because the latest guidelines have brought beta blockers as class 1 again. This is what Dr. Poulter was talking about, the top spin trial. You can see from some of these studies which have been completed and some which are ongoing that triple drug combinations are being used, and these fixed dose combinations have been very common and very prevalent amongst Indian physicians, and all of us have been very much used to actually using these combinations. They improve the compliance of patients, and these are the commonly used agents. You can see telmisartan, amlodipine, and indapamide was tried in the GMR investigators, and the top spin trial in which Dr. Poulter and one of my colleagues is also involved in this trial, the perindopril, amlodipine, and indapamide is being used here. And look at the beautiful results that you see. Actually, almost in 60% of patients, you are able to achieve home blood pressures of less than 135/85. So even with very low dosages of up to 10 milligrams of telmisartan in combination with 1.25 milligram of amlodipine, unbelievable dosages, 0.6 milligrams of indapamide, but once they combine, that is actually what is to be realized, that the effects become supplemented and the blood pressure control rates almost to 70% actually in the clinics you can achieve. There has been some work in our own country And we've done some work on telmisartan with beta blocker combination. And there was a study in JAPI in which perindopril, indapamide, and so actually, what I want to emphasize is combination therapy has always been emphasized in hypertension. All the more now people have realized its value, and gone are the days when we used to say this drug is better than that or this is better than that. Today we discuss actually and we look at combinations because we know that's how almost 75 to 80% of our patients are going to be treated. Beta blockers, a lot of Indians believe that we have intrinsic sympathetic activity, and fitness levels are different. And beta blockers, especially in young hypertensives, they definitely have a place. Although this editorial in the Lancet actually felt that the reason for bringing beta blockers in the ESH guidelines to stage 1 is actually not justified. Dr. Poulter mentioned this substitution of salt with potassium, and you can see the Forest trial has shown beautifully stroke rate, CV deaths can be reduced. We also know from the Triumph trial that even in resistant hypertension, lifestyle modification makes a difference. We know ARNIs are useful in patients with resistant hypertension, and the RDN is actually making its way again for patient treatment of hypertension, especially resistant hypertension. And look at this trial, the Quartet trial. We are now talking of the quad pill concept has come up, and trials are available in which four agents have been antihypertensive agents have been used in combination. Many more trials have come in the last 3 4 years. Chronotherapy, we used to discuss a lot whether morning, evening, what is the best time to give antihypertensive agents to patients, and now we realize it doesn't really make a difference. It's actually you could give it any time. Newer agents, aldosterone synthesase inhibitors will come up, and baxdrostat has been shown in this trial to be useful. We know the diuretic comparison showed that hydrochlorothiazide and chlorthalidone figures similarly when we used, and both these agents are commonly used in our country. The targets of blood pressure, we know the SPRINT trial showed us that in non-diabetic individuals, we must try to achieve blood pressures which are in the range of 120 to 30 systolic and 80 to 80, 75 to 80 diastolic. But this has been shown by the Chinese, even in elderly individuals beyond 60 years of age, you have equal benefits when you treat elderly. Of course, you should be careful and watchful in frail individuals. The broad study again from that country showed that even diabetics get significant benefit with the hazards ratio of 0.79, and the ASPRI collaborative group showed diabetics, non-diabetics in an open label study published last year in Lancet, significant benefit when. So intensive therapy, effective blood pressure control is the way to go with combinations, because that is the only way you will be able to achieve it. Selected group of patients, we know heart failure with preserved ejection fraction, SGLT2 inhibitors are today class 1 agents in this. And we know patients with low ejection fraction, one should be avoiding CCBs because they have negative inotropic effects. Regarding the control strategies, actually, in 2018, Dr. Venkatram was invited actually to write an editorial in the European Heart Journal when the European guidelines came. And that time we emphasized that protocol-driven standardization of treatment regimens must be implemented, and physician inertia should be tackled concurrently to achieve therapeutic objectives. And today, the WHO, actually, the heart program has given this very simplistic: start with amlodipine, increase the dose, add telmisartan, and then add chlorthalidone. The more simple you will make something, the more attractive and the more it will be followed. This is the hearts program protocol for actually for United States of America. Start with telmisartan, amlodipine, and then go on to add chlorthalidone. So such simplistic, as we emphasized, protocol driven methods of treatment should be actually shared with physicians. The India Hypertension Control Initiative is a beautiful initiative. And as Dr. Poulter was showing, the physicians in primary health centers fared better than some of us in tertiary care centers because they paid greater attention. And the way to control blood pressure, we are actually in Ludhiana, we are the first and the only private sector, because till now this trial has been used actually only in the public sector. 60 to 70% of patients actually go to the private sector for treatment of hypertension in our country. And this model we are developing to be replicated in other parts of the country. Similarly, when the Americans gave the guidelines for hypertension and new definition was given, we did, I quote from the editorial that we wrote at that time in circulation: to achieve improved control of hypertension, countries should adopt and enforce hypertension screening and diagnosis programs on a massive scale. And I would say the May measurement month is actually a beautiful actually way to attract physicians' attention towards hypertension. And this is one such CSI Great India BP campaign investigators, which a lot of us were part of. And we could actually diagnose hypertension in a very large percentage of population. But still, as was shown, the control rates are actually dismal in our country. And this actually a systematic review of population level non-intervention studies, which was published in Lancet Regional Health, only 15 to 20% of our patients have controlled blood pressure. And the new guidelines should and will emphasize to a large extent on this. This is an editorial actually we wrote in the American Journal of Cardiology last year, actually, after the European guidelines came, and we did emphasize the opportunity to improve public health by way of the early diagnosis and effective treatment. And in this, people have now realized actually that it is the implementational research which is required as to how to reach larger population of patients. We have a lot of knowledge, we have effective drugs, but how to implement this to patients and how to impart benefits to the patients. For this, greater task sharing will have to be done, extended prescription periods. People are developing different use of staff nurses to control blood pressure, digital strategies, all these out of office blood pressure, all these strategies will have to be adopted for better control. And this should and will be included in the latest guidelines that we will come out with. Thank you very much for this opportunity.
Thank you, Professor Wander, for giving us really a sneak preview about 2025. What do we expect so far as the latest Indian guidelines for hypertension is concerned? In fact, it was a very simplistic approach and gives an insight of what the physicians or the general practitioners will follow. And it's really an eye-opener also that the rural people have a better control at times rather than we corporate people do. There's something very interesting to learn. Can I invite Professor Peter Sever to deliver his talk on BP variability, mechanisms, and clinical significance? So over to you, Professor Peter.
Thank you very much. I will have one attempt to share my screen, and if that doesn't work, then I'll have to hand it over to you. Huh? It's not doing it. I think, unfortunately, I'm going to have to hand it over to you to show my slides. I'm having a problem getting the images up here. Okay, well, thank you very much indeed, ladies and gentlemen. My topic is blood pressure variability. The next slide, please. The next slide, please. These are my conflicts of interest, which don't really relate to this particular presentation. Next slide, please. No, the next slide, please. That's not the next slide. Can we go back? Can we go back? We'll go back several slides. Keep going back. The third slide. Oh,
Yes, sir.
and that is not the third slide. The next slide. No, we should. The third slide was an image of short-term variability. No, I'm afraid there's. Can we go right? I think we'd probably better go back to the beginning.
Okay.
Right. Okay. No, the next slide. The next slide. Unfortunately, that is not the next slide. And you seem to have lost a number of slides, I'm afraid.
So should I?
That is my first slide, yes. The
Yes,
second. No, that is about the 12th or 13th slide. I wonder whether it's worth trying to go back. Perhaps we should change the order of the speakers, and
Okay.
I will send you the slides again. Shall we do that? I'll send you the slides again, and
Sure, sir. You can send the
third
slides
speaker
again.
to speak now. Yes.
Yeah.
Okay. I apologize for that.
So Dr. Jabir, sir, can.
Peter, what we can do?
Yes, sir. We can ask Dr. Jabir to complete his talk in between.
Exactly.
Dr. Jabir,
Yes.
we'd like to hear from you about hypertension control, the turning point for heart failure. We all know that hypertension is one of the important seeds that are implanted, and that is a major cause of heart failure. Over to you, Dr. Jabir.
Okay. Give me a little time to load my presentation. Dr.
Yes, we
Sal,
can
is
see
my
your
slides
slides.
visible? Right.
Yes, it's visible. Please go ahead.
Thank you so much. It's indeed a pleasure and an honor to be a speaker among you all the veterans and the experts in the field of hypertension around the world. And hypertension, we have been listening to Dr. Neil Porter telling about the problem of hypertension, the poor status of diagnosis of hypertension in the low and middle income countries, and extremely low level of control of hypertension, less than 10% the control of hypertension. So we have a long way to go. But hypertension is it's an extremely important turning point for heart failure prognosis. I'll show a case of a 35-year-old gentleman. He presented to me in 1999. That time he was asymptomatic. Actually, his BP was found to be high when he was evaluated for nephrolithiasis. There was no hypertension-mediated organ damage. And we worked him up for secondary hypertension because his blood pressure was quite high. It was around 200, 110 at that time. At that time, the options for antihypertensives were also much less. We started on nifedipine. The blood pressure was not controlled. Atenolol and thiazide were added. His BP remained uncontrolled, mostly the systolic blood pressure in the range of 180 to 200 and diastolic blood pressure 90 to 100 millimeters of mercury. And later on, when the newer drugs came, we changed him over to telmisartan, amlodipine, and chlorthalidone. He was totally irregular in his follow-up. He comes once in 2 years or once in 3 years, and when we inquire, he'll tell that, oh, I forgot the drug, I'm not taking the drug properly. Every time his blood pressure was quite high. That's the story of many people who have hypertension because they are absolutely asymptomatic and they are afraid of taking drugs, fearing that the drugs may damage the kidneys, drugs may damage the brain and all. In 2022, he presented with heart failure. At that time, his blood pressure was 190 over 104, heart rate 90 per minute. His heart was enlarged. There was a left ventricular fourth heart sound and a third heart sound and no murmur. And this was his echocardiogram. So this echocardiogram shows his LV is totally bad. There is the LA enlargement, LV enlargement, LV hypertrophy. And predominantly, it's a diastolic dysfunction. So
Yeah, that is same study. Yes, recently again, sir. I just checked it.
look, am I audible there? It's hello.
Wait, so again, he has sent the same slides, sir. He just sent now the slides. The same slides again we are saying. Just now I just checked it.
Dr. Sahu, my slides are visible or not?
Yes, they are visible.
Yes,
and
they are visible.
you are
They are
audible.
visible.
But then
They're
there's
visible,
some
you're
other
audible.
noise coming in.
Yes.
So somebody was asking me the same
No,
slide.
no, no. Please continue. Please continue.
All right, all right. So this is the usual story of hypertension. Patients do not treat their blood pressure well, and finally they end up in heart failure. It may be a diastolic heart failure. It may be a systolic heart failure. The lifetime risk of heart failure is twice as high in hypertensives when compared with the normotensive people. And the long-term treatment of systolic as well as the diastolic blood pressure, it reduces the incidental heart failure in hypertensive patients. And with appropriate treatment of hypertension, all the major trials in hypertension have shown that there's a 30 to 50% reduction in heart failure. And most long-standing hypertension, it ultimately leads to heart failure, unless this sequence of events is otherwise interrupted by other outcome. And as a consequence, patients with heart failure, they are very commonly to have a history of hypertension. And when we look at the data of the Framingham Heart Study cohort, 5,143 patients, hypertension antedated the development of heart failure in more than 90%. So almost all patients who developed heart failure in that natural history of this patient, the most important predictor of heart failure or the contributor to the heart failure was hypertension. And this was during the 20 years of follow-up, that is mean of close to 50. So prevalence of hypertension associated with heart failure, if you look at hypertension accounts for around 50 to 60% of cases of heart failure, and in elderly it is close to 70%. And in patients with hypertension, in males, the risk increases by twofold, and in females, it increases by threefold. In the cardiovascular health study, and health aging and body composition study, they found that 11% of the 4,400 plus patients who were not receiving antihypertensive agents, they developed heart failure over 10 years. And the patients with a blood pressure of 160 over 100, the risk doubles when compared to those patients with a blood pressure of 140 over 90. So it is not the blood pressure alone, the blood pressure, the presence of high hypertension, the magnitude of the blood pressure, and the absence of other risk factors, the presence of other risk factors, the absence of hypertension, obesity, and diabetes in the mid-age, that is by between 45 and 50, the lowest risk of incident heart failure. So if a patient is free of obesity, free of diabetes, free of high blood pressure, his chance of developing an incident heart failure is extremely low in the remaining life course. So lived on average an additional 3 to 15 years longer free of heart failure if these risk factors are not there. So incidence of heart failure is related not only to the presence or absence of hypertension, it is related to the high blood pressure as compared to a systolic blood pressure of less than 120. It's 1.6 times higher chance of heart failure if the average systolic blood pressure is between 120 to 139, the current category of elevated blood pressure, not hypertension. And 2.2 times if it is 140 to 159 systolic, and 2.6 times if the average systolic blood pressure is more than 160. So even elevated blood pressure is a risk factor for hypertension. So if you look at the staging of hypertensive heart disease, stage 1 LV diastolic dysfunction, these are basically the hemodynamic impact of the hypertension, no LV hypertrophy. LV hypertrophy plus LV diastolic dysfunction in the grade 2, clinical heart failure with preserved ejection fraction in grade 3, and eccentric LV hypertrophy, heart failure, and reduced ejection fraction in the 4th. So gradually the structural changes in the heart is moving towards heart failure and reduced ejection fraction. Initially, it will be increased ejection fraction, LV diastolic dysfunction, then the LV hypertrophy plus LV diastolic dysfunction, diastolic heart failure or heart failure and preserved ejection fraction, heart enlarges, and it is heart failure and reduced ejection fraction. Is only the hemodynamic factors that is important. The newer concept is totally changing. It is not the hemodynamic factors. Other things are extremely important in the development of heart failure related cardiac problems, heart failure, as well as the death, even due to arrhythmias. So relative to the biomechanical stress and the disease associated molecular pathways, what happens is there occurs interstitial change in the LV myocardium, activation of fibroblasts, differentiation to myofibroblasts, and synthesis of highly cross-linked collagen type 1 and type 3, which prevails over their degradation. And finally, it is diffuse interstitial deposition of stiff and stable fibrotic tissue. So the myocardium becomes stiff and there is increased fibrosis. So this fibrosis is a key factor in the development of heart failure, as well as development of heart failure related problems that leads to mortality. And the final clinical consequences is LV dysfunction, heart failure with reduced ejection fraction, or heart failure with preserved ejection fraction. So the impact is in two ways. One is the hemodynamic impact, and second is the biochemical impact and the structural changes it produces. So hypertension to heart failure, then various factors that leads to hypertension. From the normal heart to elevated blood pressure to hypertension, which results in increased cardiac mass, arterial stiffness, arterial wall thickness, LV, RV, hypertrophy, dysfunction, LA myopathy, LA dysfunction, concentric remodeling, heart failure, and later heart failure and reduced ejection fraction after eccentric remodeling, cardiac fibrosis. And other things that are involved are the cardiovascular risk factors leading on to inflammation, activation of various pathways leading to endothelial damage, atherosclerosis progression, increased oxygen demand, and reduced coronary flow reserve. So multiple things, but the triggering factor is hypertension. And if you control the hypertension, blood pressure with a pharmacological agent quite early, you can see there is a reduction in the myocardial collagen volume fraction and reduction of the pro-collagen type 1. The pro-collagen type 1. That means early treatment with certain, this study has shown it's with torsemide and losartan, there was a reduction in the fibrosis. And growing heart failure burden of hypertensive heart disease. So patients with hypertensive heart disease without overt heart failure, and if their serum procollagen is less than 110/80, what they require is general heart failure prevention. If their serum collagen level is more high, there is anti-myocardial interstitial fibrosis guided heart failure prevention. They may require specific drugs like losartan or angiotensin converting enzyme and diuretics. So now the concept is changing.
Jabir sir, your slides were visible and you were audible also.
All right. So hemodynamic and non-hemodynamic factors are involved. Before 1950s, treatment was very poor. 40% of the deaths from hypertension resulted from congestive heart failure. And this study, pretty old study, a 3 to 5 year period of time is effective. Lowering of blood pressure over this period was effective in preventing severe disease, left ventricular hypertrophy, and congestive heart failure, in addition to the reduction in strokes and myocardial infarction. Aggressive BP control, we have data from the UKPDS, we have data from the SPRINT. 40% risk reduction for heart failure in the SPRINT if you could reduce the systolic blood pressure to less than 120, and a 57% less risk of developing heart failure with more aggressive blood pressure control, which was there in the UKPDS arm. So for each 5 millimeter reduction in systolic blood pressure, the risk of congestive heart failure decreased by a quarter, that is by around 25%. So BP reduction is beneficial for the prevention of congestive heart failure. Over and beyond blood pressure reduction, the protective effects of ACI and IRBs was found to be greater than calcium channel blocker in this study. SHEP trial, ALHART trial, treatment with chlorthalidone. They found in ALHART, the largest antihypertensive trial, risk of heart failure was much less with chlorthalidone when compared with amlodipine, doxazosin, and lisinopril. The diagnosis of heart failure had problems in the ALHART trial. Older person with isolated systolic hypertension, SHEP trial, longest follow-up, more than 30 years, a strong protective effect of chlorthalidone in preventing heart failure. SHEP study, 50% reduction in the risk of heart failure with chlorthalidone versus placebo. And 80% reduction if these patients had associated myocardial infarction. Antihypertensive treatment and development of heart failure in hypertension this randomized controlled trial from 97 to 2009, diuretics represented the most effective class of drugs in preventing heart failure, then RAS inhibitors. Calcium channel blockers and beta blockers were found to be less effective in heart failure prevention. This recent article, 13,000 plus patient, 2.4 years of follow-up, acute heart failure, 36% lower risk reduction in the if this patient had a MI or stroke history. So the ESC hypertension guidelines 2023, very clear, no confusion. Treatment of hypertension is the most important thing that is recommended to effectively prevent heart failure, class 1 recommendation. All the major classes, ACE inhibitors, ARBs, beta blockers, calcium channel blockers, and diuretics, thiazide or thiazide-like diuretics can be used for the prevention of heart failure, class 1. And given the fundamental importance of BP control for heart failure prevention, additional available antihypertensive agents can be used if this goal is not achieved by the use of 5 major antihypertensive drugs and their combination. An SGLT2 inhibitor is used for the prevention of heart failure in patients with diabetes. So drug options, all the drugs you can use. And there are certain differences. Non-dihydropyridine calcium channel blockers are not recommended once they develop heart failure and reduced ejection fraction. Diuretics, thiazide, if eGFR is more than 45 and if eGFR comes down, then we may shift over to the loop diuretics. So my take-home message regarding this topic will be hypertension is the major risk factor for heart failure. Hemodynamic as well as non-hemodynamic factors plays a major role in the pathobiology of heart failure in hypertension, and how to prevent it. Catch these patients quite early, diagnose the hypertension quite early, and treat early, aggressive treatment. Identification and control of hypertension is more important than the antihypertensive agent per se. But there is some data which is in favor of an edge for the RAS inhibitors and chlorthalidone in prevention of heart failure. Thank you for your patience.
Thank you, Dr. Jabir, for giving a full overview of about hypertension control, how it is important as it is one of the most important turning points for development of congestive heart failure. I will now go to Professor Peter Saver again. Professor Peter, the slides you have shared is the same set which was sent previously. So please continue with the slides and we can catch up during the discussion where Professor Venkatram will be moderating, and we can catch up with all the points. You can bring your points about BP variability at that point of view when we have a panel discussion. Over to you, Dr. Peter.
Shall we go to the third slide, please? And the fourth slide. Yeah, I'm sorry. The whole presentation seems to have got completely scrambled, and I don't understand why that might be. Let me have one more go using my laptop, because I have the slides on. So if you'll forgive me for one moment. Now, let me see if I can share on this one. Now, can you see my...
Yes, we can see your slides coming up. Yes, sir. Yes, sir, we can see your slides.
You can see it?
Please, yes, sir, please make it full screen.
I'll go on to the full screen.
Yes, sir.
And
please carry on,
can you hear me? Are you able to hear me?
Yes, sir, you are visible and audible. Please go ahead.
Okay, okay. Well, I'm really sorry for that. Well, let's move on. And the background of blood pressure variability has largely, historically, been focused on short-term variability, which, as you know, is traditionally measured by a 24-hour ambulatory blood pressure recording. And in the context of that 24-hour recording, information is available on the morning surge. But what I really want to focus on this evening are longer-term measurements of blood pressure variability that are largely determined from visit-to-visit readings in the clinic. Now, this is the characteristic 24-hour ambulatory trace with minute by minute and hour by hour changes in blood pressure, largely dictated by neurohumoral factors driven by the sympathetic nervous system and responding to changes in emotion and physical stress. And it was known 20 odd years ago from observations from Giuseppe Manzi and his colleagues in Milan, and subsequently many Japanese studies, that short-term blood pressure variability or increases thereof are important determinants of cardiovascular risk. And this is summarized in a meta-analysis by Stevens and his colleagues in the BMJ in 2016. But what I want to focus on is long-term visit-to-visit variability. And this is an exceptional trace. It's over a period of several years, an individual measurements of systolic and diastolic pressure without any interventions that change during that time. You can see really marked increases in visit-to-visit variability. Now, there are a number of factors that contribute to that, and this is a very complicated slide, which I'll summarize very briefly, but the evidence really is overwhelming that visit-to-visit long-term variability is largely a function of the aging process, and a number of factors are contributing to that, ranging from genomic instability, epigenetic modification, mitochondrial damage, and cell senescence. And all these will alter vascular structure and function, and particularly the development of arterial stiffness. Now, we got into long-term variability about 15 years ago as part of a collaboration with the stroke physician Peter Rothwell from the University of Oxford. And he had shown that recurrent stroke was largely determined not by individuals' average blood pressure, but by their long-term blood pressure variability. So we used a substantial database that we had derived from the Ascot population, which was an intervention trial in hypertensive patients involving almost 20,000 patients who were randomized to 2 different treatment strategies. And we used that database to try to establish the importance of blood pressure control on the one hand and blood pressure variability. Now, these data are taken from the period in the trial from about 6 months after randomization, because of course in any trial there's a lot happening in the first 6 months. Blood pressure is coming down, new drugs are being added, doses are being increased, and so on. And after 6 months and through to about 5.5 years, blood pressure has stabilized. And in this slide, what we have looked at is the influence of average in-trial blood pressure after that first 6-month period on cardiovascular outcomes, and shown here is stroke on the left and coronary on the right. And because we had almost 1 million blood pressure measurements, we were able to divide the database into deciles of average pressure, running from left to right on the slide. And you can see that with the exception of the very highest level of systolic blood pressure, the average blood pressure in the trial didn't seem to have much of an impact on cardiovascular outcome. Now, this is all unadjusted data, and if you adjust for everything, yes, you do get some sort of relationship, but it's not a very powerful one. Now we look at blood pressure variability. This is long-term, this is visit-to-visit variability throughout the trial over a period of about 5 years. There were almost a dozen readings of systolic pressure from which these data were derived. We've got standard deviation in the top panels and the variation independent of the mean blood pressure in the lower panels. But as you can see, there's a very powerful positive relationship. The higher the blood pressure variability, the higher the risk both of stroke and of coronary disease. Now then, at the end of the trial, after an average of about 5.5 years, in the United Kingdom, we flagged everybody with the what has turned out to be National Health England, where we can collect data on hospitalizations, morbidity and mortality and so on. And so we accumulated a huge number of vascular events over a prolonged observation period, which in total was over 20 years. And I only want you to focus on the left-hand side of the slide here, that during that follow-up period, excuse me, we had almost 1,000 strokes, we had over 3,000 coronary events, and we had nearly 5,000 cardiovascular events. So it's an enormously powerful database. Now then, when we looked again at the importance of blood pressure variability in relation to different cardiovascular outcomes, and you can see there coronary disease, stroke, heart failure, total cardiovascular events and renal outcomes, you can see having adjusted for mean blood pressure, though this is purely a function of blood pressure variability, there is a very strong relationship. There is about a 25% increase in risk for all of these endpoints for every standard deviation increase in the variability of systolic pressure. So a very, very powerful association. Now, when you look a little more closely at this database, what we've done here is divided up blood pressure, average blood pressure, into tertiles or thirds, from low blood pressure to high blood pressure. Now, from left to right on the slide, we've similarly divided the population up by blood pressure variability, from low to high. Now, what is interesting is that if you have low blood pressure variability, it doesn't really matter what your blood pressure is, it doesn't increase your risk very much. Now, these people have got an average blood pressure of 107 to 132 systolic. These people have got a blood pressure above 140 and increasing to over 200. So what this is telling us is if your blood pressure variability is low, your risk of having a high systolic blood pressure average is not very great. On the other hand, if you have a relatively normal blood pressure, and all these are less than 140, which was the target when this trial was done 20 odd years ago, if you had high blood pressure variability, you were at an enormous increase in risk. And of course, you would not be treated because the guidelines dictate that you treat on the basis of systolic pressure, not on the basis of variability. And in the whole population, about half the cardiovascular events occurred in people with relatively normal blood pressure, for whom at the time of the study, when the guidelines said once you get below 140, then that's fine, these are all people with high blood pressure variability that were at high risk. Now, when we went back and we looked at the population, we tried to characterize the people that had high blood pressure variability. They were the older people, they were people who smoked, they were people with diabetes, and they were people with evidence of vascular disease. So this long-term blood pressure variability, which I said a moment ago is part of the aging process, is actually associated with structural changes in the large blood vessels. It's simply a function of stiff, pathologically involved large arteries. Now, when we published our data originally in 2010, a number of other trialists and observational studies reported exactly the same finding. In ALLHAT, in the MRC trial of older subjects, in the advanced trial, and in the observational studies, the Women's Health Initiative, and then Haynes, they all showed that systolic blood pressure, long-term variability, independent of systolic blood pressure, is a powerful determinant of cardiovascular outcome. Meta-analyses have shown the same thing, and I don't have time to go into this, but this is blood pressure variability and all-cause mortality. Yes, there's a powerful relationship. So that's what the observational data and the trials have told us. But let's come now to practicalities. How do you define blood pressure variability? Well, we've spent the last 100 years trying to define what high blood pressure is. We're still changing the thresholds and the targets year by year, but we've got to start to begin to define what high blood pressure variability is. Now, this is some observational data from N. Haynes. It's not a particularly big population, around about 1,000 subjects. They were unselected. The average age was about 50, and their systolic pressure was within the normal range on average. Now, this is the frequency distribution here of the standard deviation in the normal population. You can see the mean is around about 8 millimeters of mercury. If you superimpose cardiovascular risk, you can see that there's a strong relationship. The higher the variability, the greater the risk. But those aren't the patients that we're looking at in the clinic. This is the distribution from our hypertensive patients in Ascot. And you can see the whole distribution curve is shifted to the right, and the mean now, standard deviation, is around 12. And if we were to superimpose cardiovascular risk on that, you would show substantial increments in risk when you get above about 12 standard deviation. So from a pragmatic point of view, we are suggesting that for the time being, that if you have a patient with a blood pressure variability above 12, you know that they are at increased risk. What about guidelines? Well, the only guideline that has incorporated measurements of blood pressure variability is QRIS 3 and now QRIS 4, and added to the normal risk that you incorporate into the risk score, then blood pressure variability has a small additive predictive effect. Now, how do you measure it? Well, I've been describing measurements from a clinical trial over a period of years, and from a practical point of view in the clinic, you can't do that. Well, you can, but it's going to take you a long time before you actually get any measurements upon which you might want to make a decision. It has been shown by a group in Malaysia that round about 6 determinations probably give you as good a measure of variability as any. What about home blood pressures? Well, we're in the middle of a study at the moment trying to see whether we get similar information from multiple measures of home blood pressure, because that would be a much more practical way of applying measurements of systolic blood pressure variability. And this is some very preliminary data from a BSc student project, and data from our clinic on about 80 odd or 90 hypertensive subjects in whom we had their clinic visit to variability based on 5 or 6 readings, and their day-to-day variability on home blood pressure readings. And from this preliminary data, you can see there's really quite a good relationship. So that we think is promising for the future. Finally, what about drugs? Well, very striking differences in the effects of drugs on blood pressure variability from Ascot. The red line shows the effect of the beta blocker atenolol. As soon as they're randomized and they're put on atenolol, the blood pressure variability goes up, and then it comes down again as second and third line drugs are added. Whereas the calcium blocker-based treatment shows a gradual reduction. And there are two figures there. One standard deviation, the other is coefficient of variation. They show the same thing. In Ascot, some of you will remember that the outcome there was very much in favor of the calcium blocker-based regimen compared with the beta blocker-based regimen. And when we did the analyses, it was clear that it was the blood pressure variability beneficial effect of the amlodipine-based treatment regime that accounted for these benefits on all cardiovascular outcomes. A meta-analysis of a large number of trials shows striking differences. Calcium channel blockers and non-loop diuretics reduce blood pressure variability. Beta blockers increase it. Surprisingly, drugs that act on the renin system either have no effect or increase it. And all those effects are pretty standardized. So to conclude, various measures of visit-to-visit blood pressure variability are powerful predictors of stroke and coronary disease. Other measures of variability, which I haven't really talked about today, are also predictive, but they are less convincing than long-term variability. Blood pressure variability is complex in terms of mechanisms, measurement techniques, and indices. We believe that there's sufficient evidence now to incorporate measurements of blood pressure variability in guidelines, but we have problems providing recommendations for treatment because we don't have prospective randomized trials. And the problem is it's going to be 5 to 10 years before the outcome of those trials are completed, if indeed they're ever done. So we have to make some sort of pragmatic recommendations in the interim period. And I think the evidence so far is that long-acting calcium channel blockers are probably beneficial, particularly in patients at high risk. We need to do more about how we're going to measure it, trying to find some simple, pragmatic ways of doing it. And in conclusion, future goals are to establish blood pressure variability as a new paradigm in the way in which we manage hypertensive patients. Well, thank you very much for your attention. I really apologize about the chaos of my new, very expensive computerized system at home. I had to revert to my old laptop, which was reliable. But thank you for your attention.
Thank you, Dr. Peter, but no issues. The hassles do happen sometimes. Now I request Professor Venkatram to kindly introduce our panelists, and then we can start with the panel discussion. Over to you, Professor Venkatram.
Okay. Thank you very much, PK. First of all, the four speakers covered a very broad aspects of hypertension. It looked simple, but actually very intricate aspects of hypertension were covered beautifully by all the speakers. Wealth of knowledge was transmitted. Now we will have a panel discussion. There are a lot of questions that have come on the screen that I'm going to address some of them, avoiding the duplication. We have a wonderful panelists. The panelists were chosen due to their leadership in societies and also due to their particular specialty. Dr. Vasant Kumar is a very senior physician at General Internal Medicine at Apollo Group of Hospitals in Hyderabad. He is also a diabetologist and he was a former president of RSSDI. At Apollo Hospital, besides his internal medicine, he's also head of our geriatrics. because geriatrics has become a very important component of general medicine. So he is a perfect match to be in this panel. He is, of course, the current president of Indian Society of Hypertension. Lot of experience in medicine, diabetes, and also in the organizational matters. And we welcome Dr. Vasant Kumar. We are also fortunate to have a nephrologist because hypertension, nephrology, diabetes, they're all linked together in the modern paradigm of controlling cardiovascular risk factors. We have a very senior nephrologist from Guntur, Andhra Pradesh, Dr. Avula Srinivas. A lot of experience in nephrology in the last 30 years. He is actually a graduate of Jabalpur Medical College, and then he did further training in Nagpur, and then at Sanjay Gandhi Institute in Lucknow, which is a very premier institute, he did his DM in nephrology. So his background is very interesting, premier institutes, and then he started nephrology as an important discipline in Andhra Pradesh through Guntur. He is actively involved in Indian Society of Nephrology, American Society of Nephrology, Indian Medical Association, etc. And he contributes very importantly to reduction of cardiorenal problems in the community. Now we have endocrinologist to be part of our panel. It makes sense to me to have an endocrinologist, diabetologist anytime we discuss hypertension. Dr. Surendra Kumar Sharma is a very senior endocrinologist in Jaipur, Rajasthan. He is highly trained in general medicine, and he is a DM in endocrinology from PGI Chandigarh, which is a very prominent institute for postgraduate training in the country. By the way, he's the first DM in endocrinology in the state of Rajasthan, which is a very important precedent. And now there are other people also, but he's the one who is a trailblazer of bringing endocrinology and diabetes to the state of Rajasthan and northern India. He has won a number of awards that are shown on the screen for his contributions to diabetes endocrinology, and also for his contributions to APCON. And he's a very useful and valuable addition to our panel. So, ladies and gentlemen, we have a senior physician, we have a senior nephrologist, we have a senior endocrinologist. So what I would like to do, we have to catch up with the time. I would like our panelists, starting with Vasant Kumar, to make brief comments. And immediately after Vasant Kumar, he will ask Dr. Srinivas to make the comments. And Dr. Srinivas will ask Dr. Sharma to make the comments. And then we'll go to the panel discussion. Dr. Vasant Kumar.
Yes, sir. Any particular questions that are being posed? Anyway, it's wonderful to listen to all the great speakers. We have literally revisited hypertension and its management. And finally, sir, as you know, you're all global experts, but the situation remains at the ground level pretty bad, as most of you said, that we need to detect hypertension. We need to make sure that they take the medication for the rest of the life and they monitor the sugars. And of course, the lifestyle that all of you have mentioned. And above all this, it's also important for a place like subcontinent of India and other places where the medicines that are available are affordable and are available to the general public. And so finally, it boils down to looking at 3 or 4 drugs that we need to use, whatever we talk about. We are finally, we are talking about an ARB, a calcium channel blocker, a diuretic, and in some cases, it's a beta blocker. So thank you so much. I was quite inspired by everyone's talk. Yes, sir. I will leave it to the next panelist.
Dr. Srinivas.
Yeah, thank you. It was excellent lectures by each and everyone, covered well. Yeah, the focus was on cardiac, this thing. Nephrology also deserves some mention. The kidneys are affected and are also the cause of hypertension. what we want to know from the expert panelist is the sodium in the diet is one of the major factors which is driving the hypertension. How low and how we can go and for the prevention of cardiac disease and the hypertension in particular. Apart from that, most of the things are covered well, especially the combination drug therapy and prevention of cardiac failure in hypertension, which is very, very important. Even in kidney disease, which causes hypertension, the mortality in 50% of the cases is due to cardiac complications of hypertension before there is the end-stage renal disease. Thank you, and I'll pass on to Dr. Sharma.
Dr. Sharma? Hello? I saw him earlier. If somebody can get hold of him on the phone while you are getting hold of Dr. Sharma on the phone, we will have him comment when he comes. So his role is still there, very important. Let's start with, I won't comment on anything unless there is some disagreement. Dr. Srinivas has asked a the usual fundamental perennial question about how much salt and how to maintain that salt for intake forever without so-called variability. No, we should not be like BP variability, salt variability. And Dr. Poulter commented on non-pharmacological treatment, and I'll ask him to comment, and then I will look at the screen and ask somebody else also. Neil.
Thanks, Venkat. Good question, Dr. Srinivas. Really, it's a non-question. It's been raised by essentially one bunch of work which is very poorly scientifically based. There's the idea that if we go too low with the salt, it's going to be bad for the population. But the evidence for that is appalling. It is inadequate. And I hate to say it, I think it really should be not considered alongside the generations of work which has shown quite clearly that essentially the lower the salt, the better. I'll give you one anecdote, which is much better evidence than that's been promoted for saying that low salt was bad for you. And I worked for 5 years in a remote part of East Africa in Kenya, population of 35,000 people. There were no cases of hypertension at all in that 5-year period. Everybody was on a low salt diet. We're talking about 70 millimoles per day of sodium chloride. There was a tiny intake of right across the population. I never saw a case of hypertension, and never in the 5 years that I was there was there a cardiovascular event. The evidence that you may be aware of coming out of the PURE study is observational. It's based on poor epidemiology, and I really think it should be dismissed. We shouldn't let the huge amount of evidence saying that we just need to get the salt down be distracted at all. So the lower the better is the answer as far as salt is concerned.
Neil, thank you. The other speakers, if you have a viewpoint that is opposite to that of Neil, you can say it. You can raise your hand. If you don't have an not opposing, but a different viewpoint, we'll go to the next. I'm looking at the screen. The question always comes up mainly because of Peter Sievert's talk. Because of his talk, this question has come. What is the ideal time for administration of antihypertensive drugs? If you want to give it, which is the ideal time? We know the answer, but this comes up all the time. So let me ask Peter to respond about ideal time for administration of antihypertensive drugs. Does it make any difference these days? And then I'll go to the other speakers. Peter.
Yeah, well, thanks for the question. It is a very interesting question, and I have to preface my remarks by saying it obviously depends on what drugs you are using. And if you are using short-acting drugs, then it's important that the drugs are given twice a day. But if we are using long-acting drugs, then in theory, it shouldn't make any difference. Now, there was a study from Spain that suggested that there was an enormous reduction in cardiovascular risk if the drugs were given in the evening. Now, that was followed by a very large study conducted by Tom MacDonald in Scotland, in which they randomized hypertensive patients to morning and evening doses. I was on the Data Safety Monitoring Board of that trial, and I can assure you there were absolutely no differences in cardiovascular outcome whether you gave them in the morning or the evening. Interestingly, if you gave the drugs in the morning, then the blood pressures were slightly lower in the evening. If you gave the drugs in the evening, the blood pressures were slightly lower the following morning, but it didn't appear to make any difference in long-term cardiovascular outcomes. Now, there is just one anecdote that I will add to that, which I'm sure Neil would agree with me, and that is that one of the commonest drugs we use today is amlodipine, which is extremely effective. And the problem with amlodipine are the number of people who get ankle swelling. And one of the things that we have observed over the last couple of years is if ankle swelling is mild and you give the drug in the evening, it is less likely to cause problems the following day. Now, the anecdotes are building up in number, and soon we'll have enough for a proper study. But from a practical point of view, it's very useful. But overall, it doesn't make any difference.
Then I want Gurpreet to comment, and then Neil, and then Jabir in that order. Gurpreet?
Sir, on the same issue, sir?
Yes.
Yeah, absolutely. I would agree with Dr. Peter Saver that this large study from Scotland showed, although initially chronotherapy was being debated and discussed, that it didn't really make a big difference. But I think one issue that he did raise, like losartan is largely a twice-a-day drug. So one should know what drug you are using and then accordingly use it. If it is a drug which is to be used twice a day, then might as well use it twice a day, because blood pressure control effective throughout the day and night is important. But this large study which I mentioned and sir also mentioned, actually it does allay the fears. I personally, actually, as a clinician, if I use two drugs, two pills, then I give one pill in the morning and the other in the evening.
That's fine. Thanks. Neil, you have anything different than the previous two speakers?
No, except just I think we should be giving tablets to the patients. First of all, we should use tablets that last for 24 hours. So let's stop using short-acting drugs, as is Peter's point. The original Hygieia data from Spain, I think, has been well and truly kicked into touch. The time trial showed that it makes no difference in terms of cardiovascular events, whether you give the drugs in the morning or the evening. And the one thing I agree with Peter, amlodipine for ankle edema, paradoxically, if you give it at night, the ankle edema is less. I don't understand it, but I think that's true. I think if you give tablets one in the morning, one in the evening, there's a danger that they won't take them. That's the concern. So I take one tablet, I take it first thing in the morning. It wouldn't matter if I took it first thing at night, but I think splitting it, so a BD regimen, I think raises the possibility of increasing a lack of adherence. So I would recommend whatever's most convenient, most likely to get the patients to take it.
Okay, thank you. Dr. Jabir, your personal patients are on multiple drugs. I know.
Right.
Your patients are on 7, 8 drugs. So do you have your viewpoint briefly on this, please?
when they are on multiple drugs, it's not based on the outcome data which is available from the Spanish study, which says it is immaterial. The timing is immaterial regarding the outcomes. But there are certain things which I would like to consider. One, does the patient have a nocturnal dip, or it is a reverse dip or a non-dipper? So if despite all the drugs or multiple drugs, still he is a non-dipper or a reverse dipper, I would like to act a short-acting drug close to his sleeping time, so that during the night there should be a dipping status. And if it is a short-acting diuretic, I would prefer to give it in the morning hours so that his sleep should not be disturbed. These are the two things. Otherwise, I would prefer to give a long-acting drug at any time which is convenient for the patient.
Okay, that's fine. We'll go to the next question. Only thing is, dipping and non-dipping, this physiology is interesting, pathophysiology is interesting, but most of our patients, we don't know whether the dippers or non-dippers. Most of them, we really don't know. So a long-acting drug is good enough given at any time. So now the next question is Dr. Manjula is asking, single drug or dual drug? We can make it very, very quickly unless somebody is extremely fragile and significant physical disability and postural difficulties. Probably you should give dual drug therapy to start with. Monotherapy is just for fragile patients or who are recovering from some kind of an illness. That's one. Next question is interesting. Only one country has approved it so far. ARNI for hypertension. There are 2 or 3 studies. I know it is approved with some, not restrictions, with some characterizations in Japan. ARNI lowers the blood pressure, but unless there are at least some degree of an outcome trial or a surrogate outcome trial, I don't know how it could be considered in the current formula for the treatment of hypertension. The person who is nodding his head this way, that way is Noel Poulter, and Dr. Jabir is nodding his head up and down, so he will get the second chance. Neil?
Absolutely agree with you. I don't think the evidence is there for ARNIs. I think there's no way that it got better evidence than spironolactone, for example. So I think that should be our fourth line agent until further.
We don't have any long-term evidence or outcome trials with ARNI in hypertension. As you rightly pointed out, it's all small studies. But if our armamentarium is exhausted, we are using ARB, highest dosage, calcium channel blocker, the maximum tolerated dose, diuretic, beta blocker, alpha blocker, everything. The blood pressure is not coming down. Patient is not willing for any device therapy or not fit for any device therapy. Then I think it is worth changing the RAS inhibitor from ARB or ACE inhibitor to ARNI and C, whether there can be any additional response.
My first response to that patient would be to check their adherence. If they're taking 5 drugs and they're not controlled, they're exquisitely rare. They're not taking their tablets would be my first decision, rather than turning to a very expensive drug.
Yeah, and I know there are a couple of trials, Dr. Jabir and Dr. Wander and Dr. Srinivas and Dr. Vasant Kumar. A major trial I know is being designed, not for any outcome, but the therapeutic efficacy of ARNI in Indian patients. They're going to design it. Only efficacy-wise, whether it offers any advantage, we do not know. Dr. Pradeep Chaudhary says Indian patients don't accept the diagnosis of hypertension. That is correct. A lot of times they feel that something, because they're in front of you or you're in front of them, it is high, everything is fine, echo is LVH, doesn't matter. It is a medical community that has got the responsibility of convincing the patients that it is the most powerful risk factor for global morbidity and mortality, and the diagnosis is easy and easy to treat. The convincing has to be done by the healthcare providers. Otherwise, they're often swallowed by Dr. Google all the time. Next question I never saw this question before, that hypertension in pregnancy is a compensation to uteroplacental ischemia. No, it's the other way around. Hypertension in pregnancy is not compensatory. It is not physiological. Actually, in pregnancy, the blood pressure goes down. Normal pregnancy, the blood pressure goes down. So it is not a compensation to pregnancy. In fact, uteroplacental ischemia occurs and the blood pressure goes up. Does anybody have anything different? There's nothing to justify that blood pressure in pregnancy is to be expected. In fact, it's very, very dangerous if you don't manage it properly.
And the current concept is it is the pregnancy related hypertension or hypertensive disorders of pregnancy is an additional risk factor for future vascular events.
Right. And we'll cover it up in another 10 minutes. There are some data, Neil or somebody, Neil talked about non-pharmacological, that low salt diet, if it is maintained, and salt substitute, if it is maintained, salt substitute, which is mainly potassium. Studies have come mainly from China. The salt substitute appears to lower the blood pressure most likely due to its effects on potassium. Is it dangerous that it could cause hyperkalemia? I have a comment, but Neil spoke about non-pharmacological treatment. Let him comment, then others can comment. Actually, Dr. Srinivas, I want him to comment because he sees more hyperkalemia than any of us in clinical practice. Neil?
I think the Chinese trial, the large Chinese trial, there's been a debate. What was it, lowering the sodium or increasing the potassium? I think it was both. I think the epidemiology is quite clear that if you lower the sodium, the blood pressure goes down. If you increase potassium, the blood pressure goes down. So both work. And I think that's what the advantage of the low salt product that was used tells us. We should use both. Is there a problem with hyperkalemia? Almost exquisitely no. If you look at the evidence, they've done the modeling from that trial. Even in those with raised potassium, give them the low salt, they did better because of the reduction in the sodium chloride. You know, you've never gone into a supermarket and seen a banana which says not for people with renal failure. There's 1 millimole per inch of a banana, and they're all right. And I think